So, hello everyone. I am very happy to open this session today. It's a session which is dedicated to the non-invasive prenatal testing. The non-invasive prenatal testing is actually the genetic service or genetic diagnostic service which penetrated the society fast, effectively. It is now probably the biggest genetic service offered to worldwide. Why this is so? Because non-invasive prenatal testing is actually giving a lot of confidence to families, but also to doctors, and also opens the door for other more advanced and better services based on genetic testing for families who expect their children. I am very happy to announce that we have an excellent faculty of speakers today. We don't have so much time, so I would like to ask you to keep within the minutes which are delegated. And I'm also very happy that we have a perfect gender balance in our faculty. We have 3 nice ladies and also 3 gentlemen who will speak on behalf of their institutions. So first, I would like to give the word to Dr. Stephan Busche from Germany. Would you like to speak first, Dr. Busche?
Yes, of course. Thanks. I think I will start sharing my screen. Let's see if this works. Can everybody see what I share?
Not yet, but now yes. Now yes.
Okay. Sounds great. So thanks, first of all, for having me in this session. I'm very pleased and it's an honor. I'm going to talk about non-invasive prenatal testing, status quo and novel developments. As introduced, my name is Stephan Busche. I'm responsible for lab operations, research and development and technology transfer at Eurofins Life Codex. Now, on the first slide, I show basically a karyotype. And this is not a normal karyotype. It's basically displaying chromosomes 1 to 22. One can see that 2 X chromosomes are present. So it's a girl, no Y. And we have an additional chromosome 21. And this has the clinical consequence of Down syndrome. This was derived, to be able to make this picture, invasive diagnostics were performed. A biopsy was taken. And this is kind of the classical approach to detect Down syndrome prenatally. Now, now we come already to non-invasive prenatal testing, and in our case, the Prena test. This has certain advantages over the classical DX. The picture I just showed was done after amniocentesis, which is taking the biopsy. This has an advantage of having a high degree of accuracy. However, as you really go invasive, you have a risk of miscarriage. Now, you have another classical diagnostic approach towards prenatal monitoring, and this is ultrasound. This is non-invasive, has no risk of miscarriage, but has a quite limited accuracy. And now, non-invasive prenatal testing brings together the best of these 2 worlds. It basically is required to take blood from the mother, and this bears no risk of miscarriage. However, as placental DNA is basically analyzed, which is present in the blood of the mother, it has a very high degree of accuracy. So it basically outperforms these classical approaches, either by safety or by precision. Now, how is this possible? A short statement to the scientific basis of this. In 1997, it was discovered that cell-free DNA is released from the placenta to the bloodstream of the mother. This goes via apoptosis, via cell death of placental cells. This is basically a normal state or a normal instance which is happening, and thereby fetal DNA or placental DNA is released. This is being able to be detected from week 4. However, sufficient amounts are present just from week 9. It has a very short stability, meaning that, for example, if there was ever a trisomy present in a patient and there's a second child arriving, there's no remaining placental DNA in the blood to bias this assay. This is a question we always face. And from characteristics, it's very short DNA. There are certain limitations which we can speak of if desired afterwards. I just listed them here to have them not unnamed. However, to say this straight, these limitations are very rare. How is now this cell-free DNA here monitored? We at LifeCodex, using the Prenatal test, have two different technologies: quantitative PCR and next generation sequencing. Both are high throughput and fast turnaround. However, the advantage of the QNIPT assay, which is based on PCR, is that it's cost efficient. The limitation is that it only enables the differentiation of trisomy 21 present or not. In next generation sequencing, we generate a lot more data, 10 million reads per sample approximately, which makes it less cost efficient. However, it bears the highest resolution. So currently we can see all chromosomes to be present either as they should, as euploid in a euploid set, as trisomies or as monosomies. And now we come basically, after this short intro, to what did LifeCodex do? In the past, basically, which milestones were achieved. What we did is that we launched Prenatal test in August 2012. This was the first test in Europe which basically enabled non-invasive prenatal testing and started with trisomy 21 from pregnancy week 12. This portfolio was then basically widened to include trisomy 13 and 18 quite quickly in 2013, whereas the pregnancy week from which detection of these trisomies is possible was reduced from week 12 to week 9, and this still holds true, and it's the earliest aneuploidy detection time basically on the market. When this was done, we started to work on the speed of the analysis. So initially it required 10 to 14 days. In 2013, we were at a week, and we are still basically one of the fastest in the market, now having a TAT of 3 to 4 days in average. We started to include as well the analysis of twin pregnancies and of sex chromosomal aneuploidies. I will come to a bit more explanation on what that means in the next slide. In end 2016, prior to Christmas, I remember this actually quite well, we started our QNIPT assay, our qPCR-based Prenatal test, which is unique concerning technology worldwide, and we are quite proud on having this introduced into the market. And this, as being qPCR, enables us to lower the price to make this trisomy 21 detection something hopefully every woman can afford at some point. In May 2019, we introduced non-invasive testing of fetal rhesus status. This I will not go into detail right now, but this was a milestone. And from December 2019, we can investigate rare autosomal aneuploidies, meaning trisomies and monosomies not associated with the common ones, 13, 18, 21, but all others. This is shown here quickly in this table. What we can test for is trisomy 21, which is associated with Down syndrome, and the estimated incidence across all risks is 0.3%, trisomy 18, 0.1%, trisomy 13, 0.1%. We can go with the sex, we can analyze the sex chromosomal aneuploidies, which cover Turner syndrome, Klinefelter syndrome, triple X syndrome, Jacob syndrome, and which represent or which have an estimated incidence of combined 0.5% approximately. And we have the rare autosomal aneuploidies, which are not associated with syndromes, as they are more likely to be placental, and they have other clinical associations which result in early miscarriage, growth restrictions, or fetal anomalies. However, these are as well observed in 0.34% of all pregnancies. These were today's possibilities. Now, where does the journey go to? Our next journey, or our next milestone, will be reached quite soon. We expect to launch copy number variations to be able to analyze up to 7 MB in size, or down to 7 MB in size, in the very near future, giving us the highest resolution, at least in our portfolio for now. This is as well shortly depicted here. And then one question for this for this talk here was as well, where does NIPT in general go to? So live codecs will go in lowering basically the resolution. Oh, sorry, other way around, in sharpening the resolution and lowering the size of fragments we can detect. What is happening as well, I guess, all over Europe is that NIPT is more and more recognized by health insurances as a benefit. Germany is expected to be, or health insurance is expected to be in the beginning of 2022. France has it already, Switzerland has it already. I think it will come from most of the European countries. And in the long term, what can we expect? First, again, what can we expect from live codecs? We want to expansion our QNIPT assay. We want to introduce other trisomies than 21, 13, 18 being first on the list. We want to expansion the product portfolio in general in the area of fetal health as well as in the area of women's health. And now we come again to in general more. What is currently already possible is that technical advances enable full coverage deep sequence of cell-free fetal DNA. Like currently we have approximately, or we have less than 1x coverage to enable the analysis of all these, what I showed before. You can easily go 50x. It's just a question of cost. And as costs for sequencing go down, NIPT resolution will increase and potentially cover microdeletions and even single gene disorders. And what might come in the more far future is maybe the analysis of true fetal cells via single cell sequencing. That's it for me. I hope I managed within time. I guess questions are in the end of the session.
Yes, you managed pretty well in the time. My suggestion would be to go with the questions at the end of the session if we have time, because probably not everyone is so disciplined like you. I'm very happy to be part of NM Genomics, who started the journey in Bulgaria with live codecs from the very beginning, and we are really extremely happy with the partnership with live codecs, and also part of the lectures were also part of this journey and we enjoyed working with us. Now I have the pleasure to announce the second speaker, who is not a professional. Miss Joanna Dragneva is a famous Bulgarian singer and also a good friend of NM Genomics and live codecs. She was once a customer of Prenatest, and now she's a repeated customer of Prenatest. Mrs. Dragneva, what made you be so comfortable with us, and why have you chosen to work with NM Genomics and live codecs? The floor is yours.
Yes, thank you very much. I'm very happy to be part of this conference today. And now I'm going to share my personal story with you, and I hope to be interesting for you. I can say for myself that I turned out to be a big fan of modern medicine, or medical genetics in particular. And I'm really interested in the innovations in this field, and I can say that I have already done most of the tests offered by NM Genomics in Bulgaria. I first met them and their portfolio during my first pregnancy. You know, when you're pregnant for a first time, there's so many questions spinning in your head. You don't know what to do, what to expect. And you're worried if everything will be fine with your baby. Does your genes healthy? If they're not, what should you do? And such questions like that. Then I did a huge research of the non-invasive prenatal genetic tests available on the market in Bulgaria. And in the end, I trusted NM Genomics and especially Dr. Georgiev and I wasn't wrong. The first time we only did Prena test. The results came very fast, in the expected time, 7 days, but for me, that 7 days took like an eternity. I don't know how to describe my relief and my confidence, which I have until the end of the pregnancy. After our daughter was born, we decided to make another non-invasive test, Baby Next test. I was absolutely sure that everything will be fine again, but for my surprise, I turned out that she had inherited 2 mutated genes, one of which was responsible for cystic fibrosis. So she's not sick, she's only carrier, but this news came so unexpectedly because we have no data for such a disease in both genera. Because we wanted to have a second child, we already knew that we need to do more tests for me and for my husband to see where this mutation came from and is it dangerous for our second child. Now, again, I'm pregnant with my second child, and this pregnancy, I can tell, came like a surprise for us. And again, at the 9th pregnancy week, we did a Prena test to make sure that everything was fine with our second child as well. Due to information we already had from the Baby Next test and the inherited mutated gene, this time we did gene safe test. Again, this is a non-invasive prenatal test for a wide range of genetic abnormalities. The options we have chosen were gene safe, combined risk. It provides information on the most common inherited genetic diseases, including in particular cystic fibrosis. And we did gene safe age risk, because I'm over 35 and my husband is over 40. And we know that the risk of giving birth of a child with such diseases increases with the age of the father, not only the age of the mother. With the help of these tests, conditions can be identified early and they can be detected at this early time of the pregnancy, not in advance or even at the birth, which is good. It turns out that family history is not the only indicator of the risk of these diseases, because the mutations that can cause them are not only inheritable, but they're also spontaneous. My husband and I both gave samples to see if there is any risk for our second child to carry this mutation of the genes. This time the results came very quickly. From Prena test, the results came for 3 days, which is very fast. And from the gene safe test, in a normal period, 14 days. We didn't expect these results for a long time. And to our great joy and relief, of course, our results were very good. I was the only one who carried the mutated gene, which is not a risk for our second child. And now we are very happy and relieved. We trust once again the NM genomics with this pregnancy because we have very great confidence in them, not only because they're providing great services and because of their good team they have. The team is very responsible. They are explaining in detail everything that may concern you, everything which is important for you and for your family and for your future child. If it's necessary, they contact the best genetic specialists in Bulgaria to get the most complete individual information you need. And the peace and confidence that everything is fine with your pregnancy and the future baby is developing normally, this is incredible. And we are very thankful to NM Genomics and especially to Dr. Georgiev for everything they did for us. Thank you so much.
Thank you, Mrs. Dragneva. Good words for the team, but this does not mean that I will raise their salaries. I'm saying this in advance, but you touched a very important topic, the topic of the carrier screening detection. And now with our best collaborators is Professor Alexey Savov. Professor Savov, the floor is yours now.
Okay, did you hear me? Hello?
Perfectly, yes, we hear you excellent.
Okay, I'm going to share my presentation. Let's see.
Yes.
Okay, good, success, okay.
Just put it on presentation mode, yes, exactly.
Yeah.
Very good.
I will present something interesting and we'll be glad after that to share your opinion. Actually, everybody know about existence of screening programs. You can name a lot of screening programs, for example, for different type of cancers, diabetes, etc. And it's appear even very well introduced in medical practice. I regularly encounter the problem that my students can explain exactly the aim and the organization of that screening program. Basically, there are two types of screening program. One that includes entire population and is mandatory. It's offered irrespective of the risk of the individuals. And the second approach is to direct a screening program to, let's say, cohorts of the patients that are at risk to have some medical condition. The aim of newborn screening program are to detect potentially that type of disorder that can cause a lot of problem. Actually, in that type of screening, most of the babies will be healthy, but it's really worth to be screened because even a small number of babies that will be discovered at risk to develop some disorder must be diagnosed as early as possible. The aim is really to begin the treatment immediately in order to avoid that condition. The history of the newborn program screening started in 1958 with introducing of mass neonatal screening for disorder named phenylketonuria. So, as the people say, the father of that problem is Robert Guthrie. His brother suffered by phenylketonuria, and he introduced that test by using of Bacillus subtilis and trying to discover the babies with increased level of phenylalanine by that bacterial assay. Here you can see a plate, and that dots actually are the small filter paper containing the blood from the newborn. And if you have increased level of phenylalanine, that allow the bacteria to grow, and you can see the bacterial growth around some of the sample. Newborn screening, as I told, started in early 1916, and I'm very glad to present you that map. And here in yellow is my country, Bulgaria, that started the screening program in 1979. So thinking like that, I suppose strongly that, for example, Ms. Dragneva was subjected to that screening program. Maybe some of the panelists also undergo that screening. So in Bulgaria, first was introduced phenylketonuria, and then you can see later, but not very regularly, in mass neonatal screening program were introduced congenital hypothyroidism and 21 hydroxylase deficiency. Additionally, at the moment, we can perform a very sophisticated screening for inborn error of metabolism, but it's not at the moment mass neonatal screening program. It is used like selective screening in a risk group. The aim is really to perform a diagnosis. To offer prenatal diagnosis is necessary and always genetic counseling. Just to present briefly the disorder included in screening program, in Bulgaria, the frequency of phenylketonuria is expected to be one affected in 12,000 babies. So it's mean that annually we detect 5 or 5 pregnancies, not pregnancies, newborns with affected babies. If it leaves non-treated, you can see the clinical phenotype and irreversible intellectual disability. So that's very important to provide diagnosis as early as possible in the first few weeks after delivery, and if it necessarily, to provide the treatment just through the diet and medication. The second disorder, congenital hypothyroidism, is more frequently. It's affect 1 of 4,000 babies, so we expect 15 babies early with that condition. Again, we are going to provide a therapy in order to actually avoid impairment of brain development, and the treatment is with synthetic T4 hormone. And the rarest disorder, it is really discussable. Is it worth to provide, if there is appropriate treatment, the mass neonatal screening for 21 hydroxylase deficiency? Like that, the things looks very well. As in the most countries, we provide a neonatal screening, but with some difference. As you see in that table that refer to a set of publication in last 5 years, in the Southeastern Europe, the mass neonatal screening just includes only that 3 disorder, even not all of them in the different countries. In opposite to that, the newborn screening panels that are used in the rest of European countries and not only in Europe include a lot of conditions. So why we meet the limitation? Because at the moment we didn't introduce like methods for screening tandem mass spectrometry. We use just the screening by individual tests. It is something like I can compare that tandem mass spectrometry. It's something like next generation sequencing versus Sanger sequencing that we perform at the moment. So why the most of the countries in South East Europe and including Bulgaria met that type of problem? They declare the different, let's say, reasons, maybe particularly lack of financial resources. In my opinion, the biggest problem is a lack of organization and a lack really to make a government decision that that type of screening must be mandatory for the population. Our planning is to include maybe in next year cystic fibrosis and that inborn error of metabolism, name it medium chain enzyme coenzyme acid deficiency. both can be treated very efficiently in childhood, and to avoid like that a complication. The experience in European countries really show that the neonatal screening program must be enlarged with including of the additional targets, and like that the morbidity in the population will be decreased remarkably. So implementation of the basic standard is still demanding and necessarily for my country. Thank you for your attention.
Professor Savov, excellent talk. Thank you very much. I do appreciate the comparison which you have given with the neighboring countries and also the perspectives. I cross fingers that you will be able to implement the carrier screening for cystic fibrosis.
Sooner or later will be.
Also in the scope of the fact that there is already a personalized therapy for cystic fibrosis for the much severe cases, which will come to Bulgaria soon, I hope as well. So our next speaker will be Professor Konstantinova from Varna. She is also one of the good collaborators of NM Genomics, and she has an interesting story to share. Professor Konstantinova, the floor is yours.
But for a moment, I have a technical problem. Can you help me to find my file?
Well, if you cannot find your, Professor Konstantinova, if you cannot find your file, somebody from the crew will do this for you. But is there somebody from the crew who can share the slides of Professor Konstantinova? Theodora?
Yes, Veronica will share them.
Just a moment.
Yes. Okay.
Yeah, I found it.
Oh, good. Then go ahead, please.
Yeah. Let me see what happens. Just loading, I hope.
Yes, we don't see anything.
Yeah.
Now yes, excellent. Go ahead,
okay,
please. And
well, now officially,
Professor Konstantinova, please keep the time because we are a bit late.
Yeah, I'll be very short then. But before that, to say hello to everybody from windy Varna, Bulgaria, start with a very popular issue. This is the age factor. But because there is a little bit difference between the classical ideas and the nowadays understanding, I'm having the opportunity to show you, to talk to you about this problem. Again, help please. I can't run the slides. Can you help me with that?
That's all right, Dr. Konstantinova. We will share the slides for you, and then you can tell us when to move them.
We will take care of this from the technical board.
Thank you very much.
You can go ahead.
Can I go back one slide? Can I go back one slide, please? Same problem. I can't roll on the slides.
We will do it for you.
We will do it for you.
Oh, yeah, okay. Yeah. Can I have the next slide, please? So talking about Rh blood group system, which is well known to all the professionals and the public as well, it's to say that it's a new system estimated about 60 years ago in the 40s. And because work has been done on rhesus monkeys, we have then and now the name rhesus blood group system. It's a very complex system, and it's very important because it is very polymorphic and immunogenic in humans. It is complex system because we know that there are more than 45 antigens in this system, and genes for that system is located on the short arm of chromosome 1. Next, please. A number of nomenclature have been developed in the years to theorize the inheritance of RH system, that of Fisher-Ray's, Wiener, Rosenfield. We'll just mention that one next, please, of Fisher-Ray's, because it's most popular. Next slide, please. It's most popular, and it gives us more information about the RA genes and the products of these genes. So as it's postulated in this nomenclature, the genes for RH blood group system are a set of 3 genes, and they are closely located, closely linked, and they are located on chromosome 1. And this complex of 3 genes produces proteins which are responsible for the phenotype of the RH blood group. Next, please. Genotype versus phenotype. Genotype, this is in fact the genetic makeup. It can be in a way easily predicted using the phenotype. And the phenotype itself, which we meet in the everyday practice, it's a result between the reaction of the red blood cells, this is the antigen, and antisera, these are the antibodies. Next one, please. This is only one part of the possibilities of genotypes and phenotype in RH blood groups. As you can see, the RH phenotype is only possible to be negative or positive, while the genotypes can differ according to the different combinations of the alleles in the 3 genes. These are C, D, and E gene. According to these combinations, we may have a variety of genotypes, but only 2 types of phenotype, negative and positive. Almost all combinations of the genes, alleles, produce positive phenotype, and only one genotype can produce a negative phenotype. This is when the 3 alleles in the genes are recessive. This is the first one here. Next one, please. The RH antigens are transmembrane proteins with loops exposed at the surface of the red blood cells. And according to whether we have or not antigens on the surface of the red bloods, we can be determined as Rh positive or Rh negative. For the Caucasians, almost 85% of the population is Rh positive, and the other 15% are running around with Rhd negative blood. Next one, please. This is a very simple table of Rh blood group determination, only because I want to mention that for practical use, the D antigen in this set of genes and antigens is the most important. So Rhd is in fact the type of the blood group of the person. So we have Rh positive people if the genotype is homozygous or heterozygous. Never mind, the phenotype is that they are Rh positive, and that means that on the surface of the red blood cells those people have present antigens, while Rh negative people are homozygous for the recessive allele, and in those cases, they have not antigens on the surface of the red blood cells. Next
Professor
one, please.
Konstantinova, could you please speed up a little bit?
Sorry?
Could you please speed up a little bit because we are running out of time?
Next
Please.
one, please. Next one, please. This is a slide showing the different frequency of the Rh positive and Rh negative people in different populations. Of notice is that in Asia and Native Americans, there are very few people who are Rh negative. Next one, please. Rh blood group is important because there might be a Rh incompatibility. People who are Rh negative, they naturally have no antibodies in their blood plasma, but in two cases, they can develop immune response and produce such antibodies. First, if blood transfusion, incorrect blood transfusion is performed, and second, which is more important, that can happen during pregnancy in Rh negative women who have the chance to bear a baby which is Rh positive. Once immunized, sensitized, those women may have complications and may have troubles with next pregnancies, and their babies may suffer hemolytic diseases of the newborn. Next one, please. Next one, please.
Rika, the next one, please.
Next one, please. Why there are some cases when we come out of the rules and is not what we expect to have or have no problem concerning Rhd blood group. This is because there is a polymorphism both in the genetic aspect and the phenotype aspect. When turning to classical genetics, we have to say that we have one type of antigen. This is the D antigen. But in reality, sometimes it happens so that that antigen D may bear some changes in the structure or quality, and this will change the behavior of the antigen and the way it can stimulate, immunize, or sensitize people who are Rh negative on one side. On the other side, those people can be more difficult to be diagnosed as whether they are Rh positive or Rh negative. And that is why there might be some cases where people will react not in the proper way, not in the expected way. Next one, please.
Konstantinova, you have 1 minute to conclude, please.
Okay.
You are absolutely over time.
Okay. Finish very quickly. Next one, please. So weak D, partial D. Next one, please. Next one, please. Rh null phenotype and many other antigens are responsible for cases when there might be complications not explicable by classical genetics. Next one, please. For many reasons, it is very good to be possible to prenatally test the fetus, whether it is Rh positive or negative, so that prophylaxis can be performed during and after pregnancy, after the delivery, so that there might not be developed hemolytic disease or any other complications for the mother and for the baby. These tests are now available to determine the fetal rhesus factor before birth. Next one, please. They have quite a good diagnostic accuracy, high sensitivity, and high specificity. And if we rely on the results of the prenatal testing, 0.1% of pregnant women who require anti-D prophylaxis before birth would not receive this prophylaxis if the decision is based only on these results. Next one, please. And this is one case result from prenatal determination of the RH status of the fetus, which comes out of the rules. The mother of this fetus is estimated to be RH negative, so she wanted to know in advance whether the baby is RH positive, and the test was performed. But unexpectedly, the result was like this. RhD status of the fetus is undetermined. This is because the amplification profile is compatible with a variant maternal RhD genotype. That means that she is a carrier of that rare variants, weak D or partial D, and in that case, it's not possible to predict what would be the Rh profile of the baby. But anyway, this result is very important because in this case, it's better to perform a prophylaxis for RhD incompatibility between the mother and the fetus so that there will be no complications of the pregnancy and for the baby. That was all from me. Thank you very much.
Thank you very much, Professor Konstantinova. Sorry for pressing you, but we are virtually out of time. I have to hijack some 10 or 15 minutes from the next session and give now the floor to Professor Ivanov from Plovdiv. And after that, we will be happy to have a short discussion. I hope the panelists from the next session are enjoying the presentation. I see Mrs. Gerasimova here. Dr. Ivanov, the floor is yours.
Thank you very much for the invitation. Thank you very much for the invitation. I'll try to be really fast. You do see my screen now, right?
Right, but not in presentation mode. You should press the presentation mode in order to be. There is something. Yeah. No. Yeah, exactly. Very good.
Okay. So I'm trying to go through the clinical application of non-invasive prenatal diagnostic, but for monogenic disorders, not for aneuploidies. That was the first presentation. I'm not going to stop to explain what a fetal cell-free DNA is. So basically, the clinical applications for non-invasive prenatal testing for monogenic disorders are when we have a relevant family history of monogenic disorder in a family, or we detect an abnormal ultrasound finding during the pregnancy ultrasound scans. When we have a positive family history for a monogenic disorder, probably the easiest way to determine if the child will gonna have that monogenic disorder is when we have an autosomal disorder and the father is affected by that monogenic disorder. We have two approaches in that cases. We could either do a PCR reaction. It could be a quantitative PCR or a droplet digital PCR reaction, but we know the mutation that the father is carrying, so we are looking for that mutation in the maternal plasma. And if we detect that mutation, it means the child will inherit the mutation of the father. This is the case with the de novo mutation as well. When we know the mutational status of the mother and the father, we can easily identify de novo mutations by non-invasive prenatal diagnostic. The other approach is to do NGS techniques, and this is much better approach if you ask me, because we usually do panel-based tests, and that targets quite a lot of multiple variants to be assessed in a single test. And if you do with a PCR reaction, you need to do a PCR reaction for each variant that you're looking for. In autosomal recessive disorders, there are two types of genotype that you should expect in the kit. A familial mutation may be the same in both parents, and then the proband will be homozygous. It means it's going to carry the same allele from the mother and the father. And the more common way, when both parents carry different mutation in the same gene, and we have compound heterozygous proband. Here, the approach is if we have different mutations in the mother and the father, it is easy, and it is the same when we're talking about autosomal dominant disorders. We test the paternal mutation in the cell-free DNA, and the paternal mutation is excluded. No further testing is indicated, as the fetus may be carrier for the mutation of the mother, but it's not going to be affected. If paternal mutation is detected, then we need to go with further testing and to continue with invasive methods to look for the presence of the maternal mutation in the DNA acquired from the fetus by invasive methods. Unfortunately, the detection of maternally inherited mutation is not in the routine clinical practice as at the time. There are two approaches that are used in research. One is the relative haploid dosage analysis, and the other is relative mutation dosage analysis. With X-linked and sex-limited disorder, with non-invasive prenatal testing, we can assess the gender, the sex of the fetus, and if we're talking about X-linked condition and we detect a female sex, we shouldn't worry. But if we detect a male fetus, further invasive tests should be conducted in order to have a diagnosis. Another clinical application for non-invasive prenatal testing for monogenic disorder are the ultrasound scans. So if we have ultrasound scans suggesting for monogenic disorder, this is an indication to continue with prenatal non-invasive testing. Again, there could be two approaches. If we have a sure clinical diagnosis, we can go with PCR and detection of a common mutation that causes this disease, or we can go with next generation sequencing for target of panel of genes. And with advancing of the technology, probably there will be panels of genes associated with particular ultrasound scans, as fetus with cardiac abnormality, fetus with brain abnormality. And at some point, they're probably going to be whole exon or whole genome sequencing of fetal DNA. Another clinical application is for risk families who have done carrier screening. You've heard about the carrier screening, and there is an increasing number of couples that are doing the prenatal carrier screening. If we have a family that are carrying mutation in the same gene, this is an indication for a prenatal non-invasive testing. And another thing that is emerging nowadays are the commercial companies that are offering screening for serious monogenic disorders in pregnancies that are not at risk. They don't have family history for monogenic disorders, and there are no ultrasound findings that suggesting a disorder in the baby. But this is an emerging field as well. And as a conclusion, the non-invasive prenatal testing for monogenic disorder is a rapidly developing field in the prenatal diagnosis, and it's able to offer safe and accurate testing for couple. They could either have a family history, they could have a normal ultrasound scan, or they could be from the carrier screening or the commercial tests that are available for not pregnancies at risks. And that's my presentation. Thank you for your attention.
And thank you for the nice sentence of Terry Pratchett. I adore him also as an author. So I have two questions for every one of you, but please keep the answers as tight as possible. The first question is, do you think that until 2030, we will be able to diagnose 1,000 diseases of the fetus taking blood from the mother? 1,000, not 100, not 200, 1,000. Dr. Busche, you are the first.
Well, I think technologically that's possible already. It's just a question of cost, or we are close to being able to do this. So I think it will be definitely possible. How the price will be, I don't know, but yes.
Professor Savov?
I think that can happen even soon, not in 1930s. Just remember the Gattaca movie. I think it's very necessary to do it as quickly as possible. Yeah.
Dr. Konstantinova?
I'd say we're going to see that in 230.
Good.
So,
Dr. Ivanov?
Yeah, probably we're gonna see it sooner.
So if we are still having the company NM Genomics in 2030, we will offer this, Mrs. Dragneva, to your third or fourth child. And the next question is, do you think that prenatal medicine and perinatal medicine has any limit in terms of early diagnosis? Where would be the limit? What is the limiting factor? And this time I will start from the last speaker, Dr. Ivanov. What do you think?
So probably at that point, there we have some technological limits about detecting maternal mutations in the cell-free DNA in the plasma. But when technology develops, probably we're going to have only ethical issues.
So the sky is the limit.
Yeah.
Dr. Konstantinova, what is your opinion?
I think there are no limits.
No limits. Professor Savov?
I don't think so. Actually, it's appeared that the expectation of the pregnant woman are that we can issue results that say everything is okay. It's actually it's not possible. Always we can expect that something will be omitted during the screening, any type of screening. So you know that some of the conditions are because of the novel mutations or deviations. So at the moment we are able to screen or to search for something that it's known. I think just because of the technical condition, we will still have a lot of problem.
Dr. Busche, you are the last.
Yeah, and I think all has been said. I agree there will be no 100%, and I agree as well that there will be ethical discussions and limits, but that's for limits.
Thank you very much. It was really a very exciting session, and although we jumped in the next one, I think that everybody is happy to hear such competent opinions. Now I am declaring the end of this session, giving 3 minutes time for changing the floor, and wish you all the best. Thank you very much.